I think there are two reasons why it's really important that you at least consider this option. And the first is the business case. So we know, for reasons that I'll explain a little bit later, that a ton of the growth in demand for home care services is going to be Medicaid funded. So in order to scale up and really sort of achieve a large volume of business, it might be necessary to accept public payments, including through Medicaid. And the second reason is more societal and systemic, which is that if home care cooperatives are going to be a transformative force, both for the home care workforce, for consumer services, and for ethical businesses in general in this space, I think that it's really necessary, again, because Medicaid comprises such a huge portion of growth in this space, that we figure out a way to make this model work under the Medicaid-funded system. So before we launch into the key aspects, the 6 facts about Medicaid that you want to consider, I want to introduce you to PHI first. Can you raise your hand if you were here yesterday for my colleague Allison Cook's presentation?
Yeah.
Okay, so most people here, I'll make this part brief since you probably already heard her spiel about PHI. But our organization aims to improve the quality of long-term services and supports by improving the quality of direct care jobs. So we do that in 2 ways. One way is on my side of the organization through policy research, promoting best practices in policy, and providing technical assistance to states. And the other way in which we address job quality is more directly by working with home care providers and other long-term services and support providers on the ground, implementing the elements of a high-quality job. As part of our workforce policy research, we're doing a lot of Medicaid research. So that's sort of where this is coming from today. I want to give you a perspective on Medicaid that's really focused on the direct care workers that you employ. So here are the 6 facts about Medicaid that I'd like to discuss with you today. And I realize, for those of you in the back, this looks really nice and clean and cool on my computer screen, but it's probably really teeny tiny for you, but that's okay. I'll read through these with you now. I want to start just by describing the role of Medicaid in long-term care and in home care specifically. So first, Medicaid is the primary payer of long-term services and supports in America, and Medicaid spending on home care has outpaced spending on nursing homes. Next, I want to go through how these programs are structured. First, that these programs are operated through a partnership between the federal government and the state government, so regulations at both levels will affect you. And states have wide latitude in designing their Medicaid programs. You'll often hear from health policy researchers that if you've seen one Medicaid program, you've seen one Medicaid program. We think it's so funny. But it really is true. Each of these programs in your states is totally unique. So I'm going to give you a broad overview, but as you move further along in this process, you're going to want to engage with your state agencies to navigate how the program works in your state. And finally, I just want to share a couple of bits of information about how Medicaid will affect your organization. First, because Medicaid can really shape the way that you operate your business and the ways that you train workers, et cetera. And also because reimbursement rates are going to be really important to you, and they're not always reactive to a changing environment, and then you'll have to be prepared for that level of unpredictability. So let's start with this first aspect of Medicaid, that it is the primary payer of long-term services and supports. In 2017, Medicaid constituted 52% of total LTSS spending in the country. That's because many consumers might start by paying for services out of pocket, but these services are exorbitantly expensive for the most part. The median cost of care per year is around $50,000. The median savings account for the average American today is $0. And for those people who have savings, the median is $40,000. Right, so generally people are financially unprepared for the high cost of these services. So that means they might spend down their assets and qualify for Medicaid. For those of you who are relying primarily on public or private pay dollars, is this something that you've experienced among your consumers? That maybe you've lost a consumer because they've then enrolled in Medicaid and you can no longer serve them? So the other reason for that is that Medicare doesn't cover long-term care, and the private insurance market has all but collapsed. So you might have some people with private long-term care insurance now, but premiums are going up. Underwriting is becoming more common. It's just a less viable option. So we can expect in years to come that the slice of the pie for Medicaid is going to get more filling, right? It's going to take over more of the circle. The other aspect of Medicaid is that states are really prioritizing home and community-based services over institutional care in, say, nursing home. As you can see, home care spending has outpaced spending on nursing homes and Medicaid programs since 2013, and now we're at 57% of spending on home care over nursing homes, but there's wide variation across the country in this respect. Mississippi is at the lowest. I think there's somewhere in the 25% range spending on home care. Oregon is the highest. So states that have really intentionally worked very hard to make community-based options available are much farther along in this respect. So this is due in large part to states prioritizing home care because it's a more affordable service than nursing homes, but that's also in line with consumer preferences. After years of advocacy from the disability rights community, they've really made programs more available and accessible to stay in homes and communities. So for you, this means that you're going to be part of a broader movement in this country to provide home and community-based services to Medicaid recipients, right? So you'll be part of this much broader trend and really sort of tapping into this increasing demand for services. So let's talk about how this program is run. First, by going through the shared responsibilities of the state and federal government. So the federal government sort of writes the broad direction of these programs. They interpret statutory requirements. So when the legislature and Congress changes the law, they write the rules. They occasionally revisit those rules. They provide administrative oversight and release guidance. But really a lot of the day-to-day administration of these programs is left to state governments. So they're doing the enrollment, they're actually assisting consumers. Consumers aren't really going to be interfacing with the federal government. One way in which their responsibilities are shared is funding. So the federal government pays a certain percentage of Medicaid payments, so it's sort of shared between the state and federal government. More populous, wealthier states are taking on a larger share of their own funding, whereas more rural states might have a larger share of federal funding. But really, the federal government gives states a lot of flexibility in how they design their programs. First of all, home care itself, this really important service that we're all focused on, is actually an optional benefit under Medicaid programs. Mandatory benefits include things like nursing home care and also all of the acute care services that we sort of typically think of as Medicaid benefits. But the thing is that every state covers home care, obviously. So the difference is that home care isn't always subject to the same regulations that regular Medicare is subject to. In regular Medicare, sort of like the state plan Medicaid, I'm sorry, I was saying Medicare, Medicaid, state plan Medicaid has to be statewide, so available everywhere. The services have to be comparable for everyone, so no one's getting special treatment. It has to be sufficient in amount, duration, and scope to sort of achieve the goals of Medicaid, which is to improve care, and especially to improve care for people who are poor or in poverty. Consumers have to have freedom of choice to choose among providers so that they're not funneled into one or another. But in order for states to provide home care, they have a lot of flexibility in how they structure their home care services. The way that they do that is the federal government has exempted them from certain requirements in providing home care. So moving from left to right, on the left-hand side we have state plan amendments. These have to cover all of those 4 criteria that I listed on the last slide, but they can be a little bit different and a little bit more targeted. So personal care services, this might raise concerns among states because if they're providing personal care under their state plan, one, it's got to be statewide, it's got to be available to everyone, and sort of equitable across the board. But in order to control costs, a lot of states have put limits on how much personal care they'll fund. So it could be that they have a certain number of hours that a person can't go over, or that person, in order to receive state plan personal care, they have to be below what we call an institutional level of care. So the same level of care that they would need in a nursing home, they can't quite be at that point. That's where waivers come into play. So waivers are really explicit exemptions from certain parts of Medicaid state plans. The most common one is the 1915C. This is something you're probably going to see a lot as you start exploring these services. Basically what it does is first it exempts the comparability standard. So there could be waiting lists for a 1915C waiver, so people could be waiting for these services to come through. And they might also be geographically specific, so they might not be statewide. So in this case, you might be dealing with a waiver that's specific to your region. These other waivers aren't quite as common. Community First Choice and 1915I, these are primarily focused on consumer directions, so we'll just gloss right over that. And then Section 1115, this is sort of like the most flexibility that a state can receive. It's really experimental. The state can do whatever they want, basically, and there are regulations that guide what a state can do. But as long as they get approval from the federal government and it sort of aligns with Medicaid's goals and objectives, they can do it. But really, I think that for most of you, in terms of service delivery models, you're primarily going to be working in personal care services under the state plan and the 1915C waiver. So here's just a breakdown of how many people are accessing services through each of these different programs. You can see that the lion's share are going to be enrolled in 1915C. Home health is a mandatory benefit, but this is really focused more on sort of like post-acute care. Personal care, state plan, that comes in second. That's going to be sort of like under the state plan, people maybe with lower level of care needs. And then there are these other waivers that make up the last quarter or so of enrollment in Medicaid. In addition to service delivery models, so we're seeing these trends toward rebalancing. Just to recap a little bit, we're seeing these trends toward new ways of delivering services for states. The last major trend we're seeing is new flexibility in how payments are structured. So the way this looks is primarily through managed care arrangements. Can you raise your hand if you've heard of managed care plans or managed care in your state? Oh, lots of people. Okay, great. So basically, this is a new model of Medicaid that's increasingly popular. Last year, I think there were 24 states that had managed long-term services and supports, up from 8 states in 2004. So it's really getting much more popular. Under these arrangements, the state will contract with a private health insurance plan. They give them a lump sum of money based on sort of cost trends in their member case mix, right? So based on what they think it will cost to serve each consumer. They get a lump sum payment, and then the managed care plan sort of coordinates among their provider networks and contracts with different providers to make sure that that person can get services. So managed care plans are incentivized to make services the most efficient, which means they're going to not want to spend money, right? Because whatever they don't spend, they get to keep as profit. So what this means is rather than the traditional fee-for-service model, where every hour of service is a certain amount of money that you receive directly from the state, you'll be negotiating directly with these private health insurance companies around the rate that you need and a rate that's acceptable to them. So you'll need to, we talked a lot about in earlier sessions, marketing yourselves, demonstrating your value. You'll also have to do that with managed care plans and sort of explain to them what need that you feel that they have. You might be serving a specific population. You might, for example, employ a large number of Somali workers and you're working in a Somali community. You might, for example, serve a specific rural community where access to care is more limited. Or you might have a specialized set of training that you provide to your workers. around dementia or some other specific chronic condition. These are all ways you can demonstrate value to the managed care plans. So, moving on to what this actually means for you. I want to talk first about how states can regulate your organization through Medicaid requirements. Can you raise your hand if you need to be licensed in your state to provide home care? Okay, so quite a few of you, but not everyone. So you may also, if you're entering the public pay space, you might be subject to new requirements under Medicaid that exceed the requirements of licensure. They could be around staff training, they could be around supervision, any number of things. These can all be written into waiver programs in Medicaid or in state plan personal care services. Here's an example based on our research on training for personal care rates. In 29 states and the District of Columbia, agencies have varying levels of requirements, or there are different levels of requirements for agency-employed personal care aides, depending on whether they're working under a specific Medicaid program or a private pay home care agency. In some states, and in fact in many states, requirements for training might be different across the personal care aid state plan services and the waiver services. And there might be different waiver programs for different populations. So one waiver program for younger people with disabilities and one waiver program for older people with disabilities. There are 7 states across the country where training requirements are different across Medicaid programs. So if you're accepting Medicaid payments from multiple programs at once, you're going to be having to pay attention to regulations across all of those programs. But there's also an advantage to doing that, right? Which is that you're accruing more business by providing multiple waiver services and state plan personal care and sort of having these different rates and different regulations. It might be difficult to manage, but you'll have a higher volume of business. You're making a bigger impact in your community. The last point I want to make is about reimbursement rates, because not every state has sort of like a systematic, methodical way of adjusting their rates year after year to account for a changing environment. One example of this is changes in minimum wage laws. I borrowed these slides from, not surprisingly, from a home care agency that works in Arizona. And here on the left-hand side, he's drawing out the percentage of the Medicaid hourly reimbursement rate comprised of the minimum wage. All 4 of these states, Arizona, Oregon, California, and Washington, have adjusted wages for their workers through minimum wage changes. But the difference is, if you look at the slide on the chart on the right, Arizona's reimbursement rates stay basically the same, whereas rates are climbing in line with the minimum wage in those 3 other states. So what happened in Arizona is they were receiving basically the same amount of money, but they were expected to pay workers a higher and higher wage. And that's sort of eating out of their overhead. They're using 50% as sort of like the danger zone. This is the zone in which they're getting concerned about the status of their business, the benefits they're able to offer workers, and their competitiveness in the larger labor market. The other thing about minimum wage is that also leads to compression at the lower end of the wage scale. So whereas before home care agencies in Arizona might not have been competing with retail and fast food, now they're paying the same wage. Now they're really competing with them. So this was a challenge that they had to overcome, and the way that they did it is by advocating in their state government, asking for higher reimbursement rates in a coalition with other agencies. And they were able to garner sort of like a pretty substantial increase in reimbursement rates. But look at that timeline. It only comes after 6 years or so of sort of financial pain. This can happen in other ways too, right? In an era of really low unemployment, there's such tight competition for workers. Everyone's competing for workers, and it's a real challenge. But in order for them to stay competitive on the wage side, they're having to go back to their state governments and ask for higher reimbursement rates, potentially even targeted at raising wages for workers. And that doesn't always happen. right? It doesn't always happen that states respond to that change in economic conditions. So that's something to keep in mind as well. So these are all new complexities for your organizations as you're entering the private or the public reimbursed side, especially in Medicaid. But just to revisit those two reasons that I gave at the start of this presentation, why this is worth pursuing. The first is to increase your business. Your states are continuing to roll out new waiver programs. They're trying to eliminate wait lists, make services more available through Medicaid. There's a large pool of people in Medicaid who are looking for quality, consistent care, for organizations who really value their workers and put them right at the center, right? So you're uniquely positioned in that case to sort of grow your business in this space. And then there's also the piece about making a bigger impact in this field, right? We have to find a way to make the home care cooperative model work in a Medicaid environment, because that's where so much of this growth is happening. It's so ripe for sort of the elements of the high quality job that I know all of you care so much about. But as I said, there are these new complexities. There is more that you have to think about, both in terms of finances and operations, and I know Nick is going to go deeper into that. But there are ways that you can manage that. One, like I said, engage with your state agencies. They release these really sort of dry guidance documents that can be really helpful to you as you're navigating these systems. Join their webinars. Really just engage with them however you can. They're there to help you, provide you with technical assistance. So you can have meetings and just sort of ask your questions about Medicaid, because these issues are really complicated and hard to understand, and they're there to help you through that process. My next recommendation is to work together, to work in concert with other agencies in your area. There are plenty of membership groups, both at the regional and state level, that you can tap into, so that when new regulations come down from the federal government or state government, you have someone that you can work with to understand them and share best practices in implementing. And then finally, and related to that, if you're going to enter the Medicaid space, it's really important for you to advocate for yourselves. Really become civically active. Tell your story to legislatures and tell your story about all that you do for workers and for the consumers that you serve. Because entering the Medicaid space, and again, Nick is going to speak to this in greater depth, is going to really introduce new challenges in finances. And that reimbursement rate is going to be really important. So the more that you sort of raise that issue with state policymakers, the more you're going to contribute to your own cooperative success. So here's my contact information. I'm happy to talk through any questions that you have offline. We're also, after Nick's presentation, we're going to have some time for Q&A as well. So I think I'll turn it over to Nick now. But again, we'll have some time for Q&A after this presentation. Thank you.